So my talk is on the use of machine learning to define prostate cancer margins, specifically leveraging tract biopsy for focal therapy planning. And the image you see here is a 3D representation of a tract biopsy. And the color scheme here is going to be consistent throughout this presentation. Green equals the MRI visible target. Red equals the actual cancer as defined on whole mount. Blue is the negative biopsy cores, and yellow are the positive biopsy cores. These are my disclosures. This work was funded by Avenda Health. For those of you who are unaware, focal therapy of prostate cancer is an emerging treatment option wherein only a portion of the gland is destroyed, sparing some healthy tissue and helping to avoid those really bad quality of life side effects that are associated with whole gland therapy. Unfortunately, current treatment planning modalities that are implemented clinically are a little bit rudimentary, and they entail either tracing concentric rings around the MRI visible target, as seen in the lower left, or else treating on a quadrant basis, so treating 1/4, 1/2, or 3/4 of the gland. Thank you. Now, these treatment planning strategies are not exactly optimal, and the main reason for that is that MRI continues, on average, to sometimes dramatically underestimate the true extent of prostate cancer. As you can see in the image in the lower right, MRI identified the rough location of the tumor, but it extended far beyond the confines of the MRI segmentation. And so as a result, if you try treating these cases with uniform margins, those concentric rings I mentioned, it either fails 50% of the time, even for 10 millimeter margins, or if it succeeds, it's suboptimal. It tends to treat a lot of healthy tissue unnecessarily. And quadrant-based treatment strategies are even worse. The good news is that targeted biopsy can help, and that fusion systems already do this, registering cores of MRI, providing a reliable ground truth of where significant cancer is, and equally importantly, where it is not. The lower left images are examples of MRI ultrasound image fusion, and the lower right image is a 3D representation of the kind of biopsy data we can extract from fusion systems. And we believe that by incorporating this data into a machine learning model, focal therapy margins can be improved. To that end, we accrued 114 consecutive cases with MRI, multiparametric MRI, whole mount, and no pattern 5 disease, so patients who might theoretically have been eligible for focal therapy. And we then performed a reconstruction in 3D of the tumor contours seen on whole mount after non-rigid registration with MRI. Then for each of those 114 cases, we performed biopsy simulations, 27 per case, a total of 3,000 simulations, in which targeted and systematic cores were sampled from that prostate space, and we checked to see whether or not it intersected cancer and then labeled it either blue for negative or yellow for positive. We gave those cores random variations that were derived from clinical data in their location, the registration accuracy, and the tissue length. Then for each simulation, we sampled voxels, 3.2 million voxels in all, and for each voxel, we generated features for machine learning training, features that we thought would be predictive of the presence of prostate cancer, such as distance from the positive and negative cores, distance from the MRI target, and image-based features such as texture and intensity. Lastly, we trained our machine learning classifiers using 6-fold cross-validation. We tried a number of different models, and the ones that are seen here are the results for the support vector machine, or SVM, and logistic regression. Now, the 3 colored dots on our receiver operator characteristic are the results for quadrant, hemi, and 3/4 gland ablation. The orange line is the results for uniform margins, which is a slight improvement off quadrant treatment, but not by much. Whereas the green and blue lines are the results of our machine learning classifiers, which vastly and statistically significantly outperformed all the other strategies that were tried, with an AUC of 0.9 and an accuracy over 80%. But how does this affect patient care clinically? Well, in order to assess that, we plotted treatment success on the y-axis relative to the mean treated volume of each of these treatment strategies on the x-axis. So for a mean treatment of 50% of the prostate gland, or approximately hemiablation, success rates, and success here is defined as successful prediction of all the tumor-bearing voxels. Hemiablation was successful only 30% of the time. Uniform margins were successful around 50% of the time, but both of our machine learning classifiers were above 70%, which is really incredible because these are cases that received radical prostatectomy. But we could go back and predict where all the cancer was while sparing at least half of the prostate tissue on average. And again, these results were significant. Here's an example. The whole mount slides are in the upper left, and you can see a large, clinically significant tumor in the lower left quadrant of those whole mount slides. And when reconstructed, it looks like what's seen in the upper right, wherein the actual tumor extent was far beyond through plane relative to the original MRI segmented target. But that extension was picked up on targeted biopsy. You can see those yellow cores there that intersected it. And so because of that pattern of negative and positive biopsies, our machine learning classifier was able to generate the cancer risk map seen in the lower right image, wherein we predicted very accurately where the cancer was likely to be. And if you use that as the basis for making a treatment margin, you can successfully destroy all the cancer while sparing the majority of healthy tissue. So in summary, biopsy-derived features, at least in our simulations, improved focal therapy margins, and use in machine learning classifier boosted AUC accuracy and treatment success. Future work will entail employing more involved deep learning models, validating on larger generalized data sets, and using these models and these margins prospectively in a multi-site clinical trial for office-based laser ablation. Thank you.